Hi, and welcome to Policy Unpacked, a podcast by the Global Policy Network. In this series, we dive into policies shaping our world, from healthcare to sustainability to education, and explore how these critical areas intersect to drive meaningful change. Whether you're a policymaker, practitioner, or just policy curious, we're really glad you're here. So let's unpack policy together. Hello listeners, I am Stephen Riley, the Deputy Regional Chief Pharmacist for NHS England in the North West, and an associate with the Global Policy Network. I'm delighted to host the Global Policy Network's new series, Unpacking the NHS 10-Year Plan. And today, I'm particularly excited to be joined on the podcast by Yusuf Ahmed, ICS Chief Pharmacist and Director of Medicines Optimisation. Hi Yusuf, really glad to have you with us today.
Good to be with you, Steve.
So just to dive straight in, really, what would be really good for our listeners to understand a bit more about the role of an ICS Chief Pharmacist. So, in your perspective, how has the role evolved in response to the shifting healthcare landscape?
Yeah, thanks, Steve. Good question. I guess the role of a ICS Chief Pharmacist didn't exist, as ICSs never existed. So through the last few years, as ICSs, integrated care systems, have gone through their journey of understanding their role and also working with providers and the wider system stakeholders, the Chief Pharmacist has also, I think, evolved through that time. I think there's a couple of reflections I've had over the couple of the years since we've been ICSs. I think Chief Pharmacists have evolved from the last architecture of the NHS, which was clinical commissioning groups, the CCGs, and traditional roles such as heads of medicines management, which were focused on primary care, focused on commissioning, focused on general practice, both from a strategic and guideline production, so focusing on formularies, producing guidelines, reviewing prescribing habits, being financially astute in the medicines that were prescribed in the system. That sort of traditional role that existed in the previous architecture has evolved into what we see now, where a Chief Pharmacist is involved in all of that good stuff that happened before, but also, more importantly, became the advocate, the voice, the champion for pharmacy and medicines within an ecosystem. I think I've really seen my role come to focusing at influencing, shaping the direction of travel for medicines and pharmacy, but also being a key enabler within the system of bringing different stakeholders together to champion good and excellent medicine care. So I think for me, it's doing all the things that we are used to within the medicines optimization space, but bringing it on further by looking at how does that integrate with other parts of the system? How does that integrate with hospital and trusts? How does that integrate with local authority? How does that join up with the public health agenda? How does that really join up with sectors of pharmacy that we work with, community pharmacy, and other sectors of pharmacy that we don't routinely work with, such as social care? And I think the role of the Chief Pharmacist is to be that real advocate and champion for pharmacy and medicines throughout. I think as we move into the new world of the 10-year plan, and as we moved into the new world of neighbourhoods, prevention, I think there's more to explore around the role of medicines, pharmacy, and good effective care that the Chief Pharmacist will continue to champion on. So I think, to end there, Steve, I think the essence is a lot of Chief Pharmacists have found their sort of area where they would be most effective, but it's still an evolving piece.
Really good overview there. I think you're really right. It really outlines those leadership responsibilities as well for the role, and that being the advocate, the champion, and that how it's evolved from standard traditional medicines management optimization become a much bigger, more important piece, and particularly collaborating and bringing people together across the systems and in the particular areas where you haven't routinely worked with before, and bring those out of the really crucial areas. Which brings us actually quite nicely to that consideration of, in what ways do you think the ICS Chief Pharmacist can influence national strategy and policies, such as a 10-year plan, to better integrate pharmacy services and into multidisciplinary models?
Yeah, it's a good question. I think some of the work that we've done in this space already, the network of Chief Pharmacists, ICS Chief Pharmacists, have shown some tremendous influence at shaping policy. So some of the things that you see in the 10-year plan, such as mentions of a single national formulary, for example, the importance of having community pharmacy as a central part to neighbourhoods, and other aspects such as things that are mentioned in the Model ICB blueprint around the importance of medicines optimisation team, have all come through the sort of influencing nationally that we've come together. The ICSEs currently in the current form, there's about 42 of them, and in the new architecture there'll be 25, 26. There will be a smaller group, as well as even just now a smallish group of chief pharmacists that have over time come together, one, to share some of their reflections of the role, to be a great source of peer support, but also to help bring together the thinking within the medicines optimization space and the wider ICS space. And that then has translated to a number of pieces of work that we've really helped to influence national policy. And that has been made public through the letter that we had written to the NHS executive, and then a lot of the other content that we produced to influence policy at the centre. I think we've also been really privileged to have some great champions of medicines in the national team. Dr. Claire Fuller has been a great advocate of ours and continues to be so, and our work with her directly has allowed her to influence the conversations that she's in to make sure that medicines and pharmacy teams are featured in the thinking as well as in the written material that is produced at the centre. So I think that there's clear examples of that, and we need to continue to do so. In a line to your kind of second point in the question, I think we still have to form our thinking around the value add the pharmacy can play in the wider preventative agenda, but also in the agenda within the 10-year plan. There's lots of good pharmacy content in it, but I think we still need to shape the thinking of our executives at base, but also national teams at really seeing where pharmacy could add value in the wider sense in the new NHS of the future.
That's some really key points there. I think it really shows that the role, the influence we have as pharmacy leaders and professionals is a really key element there, which is really important. And just think about some of the moving forward. In what ways do you think has digital transformation had a role in some of the work and the policy influencing?
Without it being said, digital transformation as well as digital integration is going to be fundamental to the delivery of effective pharmaceutical care, but also interoperability to deliver good pharmaceutical care across the system. So it's absolutely fundamental. Within my system, it's always played a central role in how we did business, whether it is to do with wearable technology or virtual care, or it's to do with other technologies such as apps and social media. The importance of getting your message across to patients is one thing, but the ability to have effective healthcare delivered through digital transformation is a vitally second component. What it'd be remiss of me not to mention at this stage is that digital integration for pharmacy medicines is going to be fundamental. We see that within some of the work within my system around community pharmacy. To have a single health record, absolutely essential. Many systems are working with platforms such as Connected Care and GraphNet to really look at how do we have the single source of truth across the system. That's going to be fundamental. But also the other aspect of working with different systems, and again, you can ask a community pharmacy contractor or someone working in the hospital, the number of systems they have to interface with is multitude. In order for us to really galvanize using our workforce to the fullest advantage, we need to make sure these systems work, i.e. there isn't multitude of platforms, and whatever platforms that we do have, they all talk to each other. And the other thing is around capacity. I think there's still something quite massive around being forthright with our digital integration to allow people to care for people, to allow the capacity to build within the current system, so that, say, in our world of pharmacy, pharmacists, pharmacy technicians, pharmacy support staff can really work where they really want to, which is patient-facing roles, and for the systems to be their conduit to get the job done. So I think the digital integration, as well as the journey that we're on in terms of our maturity in this space, I think is still ongoing, but it has to be front and center in how we design systems, and certainly within our system, we're thinking about it quite centrally as a component to allowing our people to do what they do best.
That's really key there. I think it really shows the importance as well, that shift from analog to digital as part of the 10-year plan. And that's what you've outlined there, some really good key points in action, how that's being worked through in real systems. You've mentioned, obviously, the importance of medicines optimization. Just from your perspective, then, how would you define medicines optimization in practice in the delivery of healthcare?
Indeed. There's a multitude of definitions. The Royal Pharmaceutical Society first defined it as 4 principles that looks at evidence-based safety, patient-centeredness, and also utilization and prescribing. So there's a multitude of principles that really go into defining medicines optimization. I like to think it in more simple terms. Medicines optimization is a principle that allows us to get the best value out of medicines, be it in relation to how healthcare professionals prescribe it or in relation to how our patients and the public utilize it. We need to get the best value out of our medicines. And for me, that simplistic description allows us to capture the core principles of medicines optimization that the evidence has described around clinical research, around evidence base, around optimization. So I think I always go to those sort of definitions. And it's important that we also be able to articulate what medicines optimization is to non-pharmacy personnel. I think that's been absolutely a crucial thing that we need to still continue to do. I still have many people in my system that ask me that vital question: what is medicines optimization, and what does it mean? And I think people have many understandings in the terms of old, such as medicines management, and other terms that have been used in the past. I think we just need to get over the aspect that it's about getting the best value out of medicines in all aspects. I also think there's something very important around how does that fit into the landscape of the NHS of tomorrow. Mm-hmm. And I think, although that's a term that's very familiar, medicines optimization, to say people that work in primary care or people that work in integrated care systems, it's not very familiar to those working in hospitals, and it's not very familiar to those working in community pharmacy. They may have come across it, but it's not akin to them. So I think we also need to look at how do we change the narrative of what medicines optimization is that chimes with everyone in our profession, but also chimes with those that are in non-pharmacy personnel, particularly our medics and our nurses and our other commissioning colleagues, and particularly those that are working in government and policy. So I think the definition of today is great. We understand it, and people that are in the know understand it. But perhaps we need to think about a different definition that allows us to really quickly articulate those definitions to people that really make the decisions, such as policymakers and non-pharmacy people.
Yeah, that's really key and really important. I think we've outlined there as well as from that understanding across the systems from policymakers, other health professional groups, and even other sectors within our own profession. That's, I imagine, one of the key challenges in actually implementing medicine optimization strategies is that lack of understanding and awareness. And I think that communication, from what you've outlined, is really key to helping deliver those strategies across our systems. And what do you think the role of medicines optimization is in the 10-year plan?
That's an interesting question because it's not clearly articulated what the role is. There's really great conversations around the importance of having medicines optimization teams. There's a focus in a sector, community pharmacy, within it. But there's really not a clear definition of what exactly it is. Is it in relation to pharmacogenomics? There's a strong mention of that. Is it in relation to AI and the technology revolution? Again, that could be something assimilated to that. Is it in relation to the delivery of neighbourhood teams? I think it's all of that and more, but it's about where do we see it in that evolution of the 10-year plan. I keep saying to colleagues, it's a 10-year plan. We don't need to deliver everything tomorrow or in the next 2 years, but it's about how do we have that trajectory of getting to those places that we want to get to have I would love there to be a panel test that tells me that which drugs from a genomic profiling are most susceptible for a particular patient. I'd love to get to that stage. I appreciate that there's a journey to get to that. So medicines optimization teams for me in the 10-year plan have to really focus on what they do best, i.e. provide that overarching governance, assurance of how medicines are utilized, prescribed, administered and given within a particular system. So we really need to think about those core aspects of medicines optimization around good formulary management, the production of guidelines, the support around education and training, the delivery of a workforce strategy that allows pharmacy professionals to really get the most out of working in the system. But also some other aspects, such as the collaboration with different providers within a system, the convener role, bringing together expertise to shape the journey of how medicines are utilised within a profession, within a system. So I think there's a number of real good quality, safety, and wider prescribing agenda, but also at the same time a clear leadership, clinical leadership, professional leadership that has to be fundamental as a component for medicines optimization teams in the delivery of the 10-year plan. That's notwithstanding the fact that we need to work collegiately across the entire disciplines within our ecosystem. And I think that's also fundamental. What I've been really proud of is pharmacy professionals are really good at bringing people together. They're also really good at providing the science to the conversation, but they're also very, very good at championing the patient voice. And I think we need to recognize that in the conversation as we move forward, play all of those three cards strongly into the design of systems for the next 10 years.
That's so important. And I think what you mentioned there as well around the collaborative approach and working together is a really important aspect as well. So obviously you made reference obviously to integrated care boards, and just for our listeners, the integrated care board is the organisation responsible for the commissioning and funding of services across their low patient population locality within their respective regions, within their areas across the country. So just within the thinking around the collaboration and what have you, what mechanisms or governance structures do you think will help the alignment of integrated care board priorities and the operational goals of providers in delivering the 10-year plan?
Yes, it's a great question. I think there's something about a unified decision-making body when it comes to key decisions, whether it's related to medicines, and I can give you an example shortly within my system, or it's related to other priorities such as safeguarding, infection control, other aspects. So I think there's something about how do we simplify the decision-making and oversight structures within integrated care systems that allows people to debate, discuss, but then come to a decision and move forward from that. So I think there's something for me that's vitally important in the ecosystem of the future, is having a clear and a concise governance structure for decisions as well as for discussions. Within the world of pharmacy in my system, we have a single medicine board, which is supported by a number of subcommittees. The subcommittees I always think are the engine room. And these subcommittees are additional primary care, secondary care committees, EMS, antimicrobial stewardship committees, safety committees in the medicine space, workforce. So a traditional, as you would expect, a number of subcommittees that really are the areas where the discussion happens and the meat of the conversation happens. And the medicine board acts as a unifying central source of ratification, which allows us to really get the business of the system through, but also allows us to make sure we kick the tires of any decisions at the subcommittee level. And I think that also has helped us to really shape some of the conversations that we have with regional colleagues and national colleagues, and how those subcommittees really tap into the expertise in the wider ecosystem of healthcare. And I think that blueprint for me is fundamental as we move forward into a complex environment of larger geographical areas, more providers coming into it. It's about where do we have the engine room to discuss, and then where do we have the decision-making ratification entity. And that description to me lands really well with executive colleagues. It helps them to really go to a single source of truth when it comes to medicine. So, for example, my chief exec will know to come to the medicine board if there's any questions in relation to medicines, and also seeks advice from our medicine board when they make decisions at exec. So I think that's going to also not only help the ecosystem make decisions, but also executives and decision makers to really understand that a particular production of a document from, say, the medicine board has really gone through the ringers to make sure that it's suitable for their system.
And that's really helpful with the oversight you've given from the governance approach in there, but you've given a really great example there as well of a cross-system and cross-system and cross-provider collaboration within that medicines board, the subcommittee, the different people who've got the stakeholders. That's a really great example of how your system's delivering some tangible progress already towards some of the ambitions of the 10-year plans. That's a fantastic example and approach there you seem to have in yours. and hopefully a blueprint for that others can utilise to deliver in their systems as well as things move forward. As you quite rightly say, it's much more complex ecosystems are going to be developed in this new NHS and new world. Just thinking about some of the opportunities now within the 10-year plan. What the overall role of pharmacy is in the 10-year plan? You've covered bits of this, but what do you crystallise some just very key basic principles for it?
I think, I've thought a lot about this, and we've had lots of conversations since the 10-year plan has been produced. I think this for me fundamentally is an opportunity for pharmacy. Number one, it's an opportunity for us to do what we do best. So in, say, some of our sectors, such as community pharmacy, we are real champions of population health who understand their people, but also are the cornerstone of healthcare on the high street. There's an opportunity within the 10-year plan to really spotlight that particular practice of pharmacy, and for that particular practice of pharmacy to be a central component of the design of, say, a neighbourhood or the primary care service. So I think it's an opportunity. It's also an opportunity from the regards of how important medicines are to healthcare. I think it's landed from various angles, from a financial angle, from a safety quality angle, but also from an intervention angle. It's landed with those people in policy making decision entities, as well as those delivery provider arms, that medicines are a fundamental component to how we deliver effective healthcare and are going to feature centrally in the delivery of the 10-year plan. Everything we mentioned around digital, around AI, around genomics, around the left shift have a feature of medicines as part of the discussion. How can we achieve the preventative agenda? It's about early diagnosis. It's about reducing harm from medicines. It's about proactive management, and medicines feature central to that. So I think it's landing with those that make decisions, but also those that design systems. A medicine professional who is expert in medicines is going to be a central part of the team. So again, the opportunity is also that pharmacy is now having even a larger voice in the wider National Health Service conversation, that it has to feature as part of the decision making, has to feature as part of being a seat at the table. So again, the opportunity comes from our ability to influence that design. And the third opportunity within the 10-year plan is that it puts an element of funding requirement support, as well as strategy and legislative support on pharmacy professionals across the sector. So what I'm trying to get at here is that it allows pharmacy professionals to, in the 10-year plan, it allows us to have a conversation with our peers and our professionals to say that our value to the delivery of patient care is X, Y, and Z. So we can say from our sectorial position, but also from our position as professionals, that we can actually make a transformative impact to healthcare. So it opens the door for a better conversation and allows us to utilize the policy, the 10-year plan policy, to spotlight where we can add value in those different sectors.
Yeah, so that's really helpful. Really great overview there of key sectors, key elements, and the real key things pharmacy overall we can deliver within that plan, and what we can do for ultimately patient care, which is why we're all here to support that shift and process. So finally, now we come over to questions from guests. So in this series, we're asking our guests to give the next guest a question. So last week, Amena asked, how feasible do you think a national formulary really is, and what obstacles would you foresee in its implementation?
Well, it's a great question. I've written quite a lot around the single national formulary. I think there's pros and cons to it. There's a real pro that it helps us to start unifying some of our decision-making entities that we talked about. It allows us to make a more consistent approach to how we deliver medicines across the country. It also perhaps streamlines some of the bureaucracy that currently exists. So, some of the architecture around governance that we talked about, having a single national formulary that allows us to perhaps circumnavigate that and have a national direction on how we use medicines. It also allows us to get more of our clinicians on board, i.e. showcase that the decisions we're making has a robustness to us, which has been nationally critiqued. On the flip side, there's many cons to it. What do you actually include on a single national formulary, Steve? Yeah. And there's a conversation that we don't want to recreate the BNF. There's also a conversation, do we focus on, say, innovative and specialized medicines and leave the rest to systems? There's also a conversation, is it for early access and us to have that? So there's a number of narratives. I think in that particular point, I think rewriting the BNF or having a very comprehensive formulary will be a difficult thing to do. I think we need to be targeted in our approach and see what will support systems. Remember, formularies already exist, as we know, Steve. It's about what can we add value to the current conversation within formularies. That's the question. The other kind of con to it is that it might alienate clinicians. So, as we say, on one side that you might have clinicians coming aboard, it might alienate clinicians. The choice aspect, what is a non-formulary process, the ability to reduce clinician preference, they really want to hold on to that, and rightly so. Most clinicians I have come across understand the importance of a formulary and will work to that, and will have a small section of patients that they believe, and rightly so, that don't feature into that formulary. I've always accepted that, and most clinicians accept that. And I think a national formulary might alienate them to say it's more control and less patient and clinician driven choices, more control. Yeah, really great avenue to go down.
It's some really good points there. You're quite right. I think some really good key potential wins from having this national formulary, the consistency approach, and opportunities. By saying maybe it's a case, do we agree a more niche approach to a specific rationale for it, and maybe it's a targeted area, rather than rewrite the BNF, or we just bring together everything we've got everywhere else. And I think the other challenges you've quite rightly outlined. It's all well and good having a national formulary, but getting people to use it and stick to it will be a completely other task altogether. So our next guest is Uzo Ebekchukwu, the Director of Pharmacy and Medicines Optimisation at the Royal United Hospitals Bath NHS Foundation Trust. So, Yusuf, is there a question that you'd like us to ask Uzo?
Yes. So I think what would be useful for me to ask Uzo is around his ambitions on workforce transformation within a 10-year plan. In particularly, what are the core skills that pharmacy professionals need to have in the future? And secondly, I'd be really intrigued to understand what would his ideal pharmacy team look like across the system.
That's a really great question. I'll put that to Uzo. That'd be fantastic to get that insight. That's a really great question, that one. So unfortunately, that's all we have time for today. So again, I'd just really like to thank you, Yusuf, for your time and your insight. Before we go, is there any final thoughts you'd like to add?
I'm excited for the future of pharmacy. I think there's challenges and opportunities ahead. I think it's in our gift, and we need to continue the conversation to influence the right people to make sure that the pharmacy voice continues to be heard.
That's a really great message to leave in there, so that's fantastic. Thank you very much for that. So everyone, if you've enjoyed this episode, please join us again next time when I sit down with Uzo Ebekchukwu, the Director of Pharmacy and Medicines Optimisation at the Royal United Hospitals Bath NHS Foundation Trust. And remember to follow GPN on social media and keep a lookout for new episodes each week. See you next week. Thank you for joining. Goodbye, everyone.